Hi, I'm Dr. Bhargava. Welcome to this short video where I'm going to show you 20 interesting body imaging cases. Here's our first patient, and we see two images from their CT scan showing this density in the region of the left adrenal. This has a focus of air and an air fluid level. And on this coronal image, we see that this is communicating with the fundus of the stomach. Here's the stomach with its thick wall. It is collapsed. Here is a lumen. And we see a diverticulum coming out of the posterior wall of the stomach. And on the axial image, we find an air fluid level. So here's a good example of a gastric diverticulum. This can be confused with a mass in the left upper quadrant, especially if there is no air, and also can be confused with an adrenal etiology or an adrenal lesion. Here's our next patient. These are images from a patient's FDG PET-CT study focusing on the anal canal, where we see this ring-shaped uptake, and this is physiologic uptake in the anal sphincter. And there is at rest some tone in the anal sphincter, and the muscle uses FDG, and it can be seen as ring-shaped uptake on a PET scan. A normal variant that we should be aware of. Here's our next patient, and this patient has pelvic floor descent. We can see a large part of the pelvis is outside their body, descending inferiorly, seen right here on the sagittal image as well. And a part of the urinary bladder and ureters have also herniated down below in the prolapse, leading to left-sided hydronephrosis. This is an interesting patient. They presented with abdominal pain. Their lipase level was elevated, and on this MRI of the abdomen, we see two images, a axial T2 weighted image and an axial T1 weighted image with contrast. So on the T2 weighted image, we see this large complex collection around the pancreas. This is the pancreatic parenchyma. But on the contrast enhanced image, we find that there is no enhancement in the pancreatic parenchyma. So this is a great example of necrotizing pancreatitis, where the entire parenchyma is necrosed and it shows no enhancement on the contrast enhanced images, and it shows almost normal signal on this axial T2 weighted image. Next patient is a young female who presented with abdominal pain, and on their CT of the abdomen and pelvis, we see this metallic focus in the distal stomach. And whenever there is something metallic, we see these artifacts which make it hard for us to identify the object or a foreign body or a post-surgical or a post-procedural change. And in that situation, a good thing to do would be to inspect the scout image that comes with the CT scan. So here is the scout image, and we can see that this swallowed metallic object is a ring. She also has rings on her nipples bilaterally, and talking to the patient, she confirmed that her nose ring was missing, and she had probably accidentally swallowed the nose ring, which we now see in the stomach. Here is another interesting patient on their MRI of the abdomen. On the T2 weighted image, the coronal image, we see what looks like hydronephrosis involving both kidneys, and we see the similar finding on the axial T2 weighted image as well. But on inspecting the contrast enhanced image, we find that there is normal parenchymal enhancement, and on the axial image, we see the ureters on both sides. And so this finding, which is T2 hyperintensity in the renal hilum, is consistent with peripelvic cysts seen bilaterally in a symmetric fashion, mimicking hydronephrosis. This next patient underwent a multi-phase CT of the liver, and we do these studies in a non-contrast enhanced phase. We do an acquisition in the arterial phase, portal venous phase, and the delayed phase. In the subcapsular aspect of the liver, there is a heterogeneous collection, and this collection shows hyperdensity on the non-contrast enhanced image, suggesting that this is blood or hematoma. And as we go through the arterial, portal venous, and delayed phases, we see that there is no contrast extravasation. So this is a great example of a subcapsular hematoma seen in the liver without any contrast extravasation. Next patient has a advanced cervical cancer. We are looking at their PET-CT fused image using FDG. Right here, the axial image showing the primary that is locally advanced, and this is a corresponding MR showing this very irregular spiculated tumor arising from the cervix with bilateral parametrial extension and probably involvement of the posterior wall of the urinary bladder. She does have metastatic disease in the abdomen and pelvis. All of these tiny foci suggest metastatic disease. And the interesting finding is the nodule at the umbilicus here. This is the soft tissue density, which is hypermetabolic. And this is known as the Sister Mary Joseph nodule, an eponymous finding of metastatic disease to the umbilicus from a abdominal primary. This single image is from a hysterosalpingogram. We see the catheter with the inflated balloon in the lower uterine segment, and the contrast has been injected. This contrast has spilled into the intraperitoneal compartment on the left side. We see that right here. And on the right side, we see this curvilinear focus of contrast accumulation, and this is the fallopian tube that is dilated and distended with contrast, making the diagnosis of a hydrosalpinx here. The next patient underwent an MRI of the pelvis, and on the top we have T2 weighted images in the sagittal, axial, and the coronal projections, showing a T2 hyperintense focus in the left side of the uterus. So this right here is the uterus, this is the endometrium, and we see this T2 hyperintense focus, which is also T1 hyperintense on this T1 axial non-fat saturated image. Here is the T1 axial fat saturated image, and here is the contrast enhanced image. So this finding, there is some restricted diffusion here peripherally in this lesion, and all of these findings are consistent with hemorrhage inside a fibroid, and this is called red or carneous degeneration from hemorrhagic infarction of a leiomyoma. This next patient underwent a CT of the chest, a CTPE protocol, and the interesting finding here is that if you look at the coronal image, there are filling defects seen in the left and right pulmonary artery branches in a symmetric fashion, where they are not punched out defects which the clots show up as, but there is gradual dilution in the concentration of the contrast as we go from the proximal to the distal part of the vessel. And this finding is suggesting that this is an artifact, not actual PE. If we look at the rest of the images, we find that there is reflux of contrast into the IVC and the hepatic veins. There is biventricular dilatation, and also there is on this lung window mild interstitial pulmonary edema and also bilateral pleural effusion. So they have signs of heart failure, and because of heart failure, we see this flow artifact which can be falsely positive for acute pulmonary embolism. So very important to remember this artifact, especially in heart failure patients. This next patient has a left ventricular assist device, and there is a catheter that is attached to it that goes through the abdominal wall. It's called Driveline, and frequently we perform CT of the abdomen and pelvis to look for infection around this catheter. And so as we look at this catheter on this axial image, it is surrounded by fluid, and at the periphery there is enhancement, so there is abscess formation. Here we see one wall, and here's the other wall of that collection. So this is how a Driveline infection would look like on a CT of the abdomen and pelvis. This next patient has metastatic prostate cancer. Excuse me. Here is abnormal activity in the prostate superimposed with some urinary bladder activity. Here we see the bladder and the prostate behind it. So these two images are frontal and lateral projections from the MIP image of a PSMA PET-CT using gallium-68 PSMA. We see physiologic uptake in the lacrimals, salivary glands, liver, spleen, excretion from kidneys into the bladder. These foci here in the pelvis are metastatic prostate cancer. But right here in the neck, we see an interesting artifact. In the posterior aspect of the neck, we see multiple foci of increased uptake in a linear pattern. Also in the region of the sacrum, we see a similar finding. So this is physiologic uptake in the ganglia that we see frequently in a PSMA PET-CT. Here are more images showing metastatic disease to the bone, to the lymph nodes, and physiologic uptake in the ganglia, in the sacrum, and also the celiac ganglia showing uptake of gallium-labeled PSMA. Here's our next patient. They presented with a very large inguinal hernia, and inside the hernia we see a loop of the colon. This loop of colon shows circumferential mural thickening and mucosal enhancement suggestive of colitis inside the inguinal hernia. So whenever there is an inguinal hernia, we want to tell in our reports how big is the hernia, which side is it, what structures are contained inside the hernia, and if there are any complications related to hernia such as inflamed bowel, acute appendicitis, bowel obstruction, infarction, strangulation, things like that. This is our next patient. On this single plain film, we find that they have a Dobhoff tube, and this Dobhoff tube is misplaced. There are sternotomy wires here, and through those wires we have to find this tube that comes down the esophagus and is folded upon itself, and it goes back, and its tip lies here in the upper esophagus. So these findings are very important to recognize on a plain film and report to the provider that this is malpositioned catheter and it needs to be removed and replaced. This is our next patient. We have two images from the CT of their chest, the coronal image and the sagittal image, showing characteristic motion artifact seen as a step ladder or a staircase appearance. So whenever you see this, the break-in image at multiple levels on a reconstructed coronal or sagittal image, this is motion artifact. This is a single image from the MRI of a patient where they have a hepatocellular cancer, and this image is a T1 weighted image, fat saturated image, and a delayed image showing washout of the contrast from a tumor that is growing into a hepatic vein and through that into the IVC and occupying the right atrium. So this is tumor in vein, and the tumor has grown through the IVC, intrahepatic IVC, into the right atrium. So remember, HCCs can be locally invasive. They can invade a hepatic venous branch, a portal venous branch, bile duct, or invade the liver capsule to go through the diaphragm, or inferiorly to involve the adrenals. And this recognition is important on imaging because that makes the patient not a candidate for curative treatments, and if a local invasion is recognized, then that makes the patient a candidate only for palliative treatments. So this would be LR or LIRADS, tumor in vein, or TIV. This next patient is known to have MEN type 2B, and they underwent a gallium-68 dotatate PET-CT. We see increased uptake in both lobes of the thyroid, and we see increased uptake in enlarged adrenals on both sides. And we know that patients who have MEN type 2B can have medullary thyroid cancers, and they can also have pheochromocytomas. And so this is their rotating image showing the same findings: physiologic uptake in the pituitary and also in the liver and spleen. And so they were diagnosed to have bilateral medullary thyroid cancers and pheochromocytomas. So this is these are images from their contrast enhanced CT showing a nodule in the right lobe of thyroid, a nodule in the left lobe of thyroid, a mass in the left adrenal and also another mass in the right adrenal. Here's our next patient. We have anterior and posterior whole body images from their I-131 study. They were treated with high dose of I-131 after total thyroidectomy when they were diagnosed with thyroid cancer, and we typically call these patients back 1 week after high dose treatment to look for any additional sites of metastatic disease that may be seen. But here, interestingly, we find uptake outside their head in their hairs on both sides, also in their hands and in their feet. And so this is a great example of hyperhidrosis, where this patient sweats more than usual, and we know that I-131 can be excreted in urine, sweat, and saliva. And so 1 week after their treatment, some radioactive iodine has accumulated through their scalp into their hairs, and some is seen in the sweat in their palms and also in their feet. So an artifact that needs recognition on these post-therapy I-131 studies. Here's our last patient for this series, and we were doing a carotid ultrasound. The right vertebral artery shows antegrade blood flow right there, but the left vertebral artery shows retrograde blood flow. That means that the direction of flow in the left vertebral artery has reversed. And we know that that happens when there is the phenomena of subclavian steal. And this is a representative CT image from their CT of the chest showing the patent branches from the brachiocephalic and the left common carotid arteries, and the left subclavian artery is completely occluded. So when the left subclavian artery is occluded, this is the artery that supplies blood to the left upper extremity. In those situations, the left upper extremity is perfused by retrograde flow from the left vertebral artery. So this is a great example of subclavian steal. Thank you for watching.